Quý thầy cô, quý vị đại biểu, chúng ta đến giờ làm việc của viên buổi sáng nay. Thì xin mời thầy cô cùng với quý đại biểu ổn định chỗ ngồi, chúng ta bắt đầu làm việc. Bài đầu tiên tôi giới thiệu là giáo sư Masanori Inoue sẽ trình bày bài về Classification and Treatment of Renal AM. Masanori Inoue là giáo sư của Đại học Keio University Radiology School of Medicine. Giáo sư đã có rất nhiều bài báo về điện quang can thiệp và là thành viên của nhiều hội điện quang can thiệp. Từ năm 99 đến 2000 thì là học ở 2002 là ở Đại học Keio University. 2002 đến 2005 là resident ở Kawasaki Municipal Hospital. Fellowship 2005 đến 2006 ở Keio University. Và 2006-2007 thì làm việc ở bệnh viện Kawasaki. 2007-2012 thì làm việc ở Đại học Keio University. 2013 đến 14 là ở Haratsuka City Hospital. 2015 đến nay thì làm Chief of Staff Radiology Keio University. Và 2019 này là Assistant Professor of Radiology Keio University. Cái lĩnh vực mà nghiên cứu của giáo sư là về coil ablation, treatment of AVM, treatment of vesical artery aneurysm, treatment of pulmonary AVM, lymphatic IR, cyclobination of lung binary IR. So please, Professor Inoue.
Okay, thank you, Chairperson, and good morning, everyone. I am Masanori Inoue from Keio University, Tokyo, Japan. And it's my great honor to be here and to make a presentation. So that today my topic is the classification and treatment of renal AVM. I have nothing to disclose with respect to this presentation. So first, I'd like to talk about the background and the general issue about the renal AVMs. Then I'll move on to the new classification, embolic material, and finally I'll show you some cases and treatment strategies. So the congenital renal AVM are rare congenital vascular disorders that involve the abnormal fistula communication between the artery and the vein through an enlarged tortuous group of vessels called the nidus, of course nidus. And a successful endovascular treatment of a renal AVM is a complete and permanent eradication of the nidus. And historically, congenital renal AVM is classified into two types, sarcoid type and aneurysmal AVF. However, these days, I think that these types cannot classify all renal AVMs. So that recently, the new classification was reported from a few papers. So in the left side, you can see the aneurysmal type. On the right side, you can see the sarcoid type. But in the middle, what type is this? So before I introduce a new renal AVM classification, I'll show this classification. This is a very famous AVM classification from the Do and Cho from the Korea. They classified the peripheral AVM into three types: Type 1, Type 2, and Type 3. Type 1 is a AV fistula, one or few arteries shunting to the venous and dilated venous vein. And in the Type 2, you can see the multiple arterioles shunting to the initial venous component. In the Type 3, you can see the multiple communication shunt between the arteriole and the venules. And based on these findings, recently renal AVM is also classified into the three types. First one is the type 1, a single or few arteries shunting to a dilated single drainage vein. It is corresponding to the classical unusual type. And in the type 3, there is a multiple shunt between the arterioles and the venules, forming a complex vascular network. Type 3 is corresponding to the classical sarcoid type. And type 2 is a new classification, multiple arterioles shunting to a single initial venous sac. So this is the clinical features of the renal AVM. The common clinical manifestation differ between the different types. For example, in the type 1, hypertension and heart failure is frequent. On the other hand, in the type 3, hematuria is the most frequent clinical features. In the type 2, we don't have so many information. However, based on some papers, also the hematuria is frequent. Why in the type 3 the hematuria is so frequent? Because the abnormal fine vessel lie just beneath the urothelium. So that this results in the hematuria. So when we treat the renal AVM, what's the target? In the type 1, target is the feeding arteries. However, in the type 1, usually the flow is very fast, and so we need the flow control using a balloon. So in the type 2, the target is a large initial venous sac. So, but sometimes approach to the initial venous sac is very difficult. So in type 3, target is a multiple shunt between the arterioles and the venules. So we must cannulate this fine shunt and using the liquid embolic material to embolize the shunt. So in the type 1 and type 2, main embolic material is coils or the vascular plug. And also sometimes we use glue and the alcohol in combination with the coil. But the main embolic material is coil. And in the type 3, of course, the target artery is very fine and tortuous, so the liquid embolic material is required. So this is a potential complication after the embolization. Of course, the renal infarction, renal dysfunction, and the renal hypertension are potential complications. However, the most critical complication is the venous thrombosis and the pulmonary embolism. So after we embolize the very high flow type 1 renal AVM, and if the type 1 AVM has a large venous barrix, there's a high risk of venous thrombosis and pulmonary embolism. So that in this kind of case, in my university, usually we administrate the heparin to the patient. Administration of heparin is continued for a few days. After that, the anticoagulation therapy starts. So I'll move on to the type 1 renal AVMs. These are all the type 1 renal AVMs. For type 1 renal AVMs, under fluoroscopic guidance, catheter is advanced into the fistula and fistula are occluded with coils or plugs. And however, in the most cases, the flow is so fast, so that we use balloon to control the flow. And if possible, the embolization of the embolization should be performed just distal to the normal branches to prevent the renal function. So this is a case of type 1 AVM. You can see that the left renal artery are so dilated. This is a single feeder case. I advance the guiding sheath into the shunting point. And also I inserted the balloon catheter to the shunt. And also I advance the micro catheter through the balloon to the shunting point. So if we insert a coil without the balloon occlusion, what's happened? It's like this. Flow is so fast. So there's a risk of migration. So in the most case, I use balloon for the flow control. And inserted coil. Now coil is very stable. It's a final result. Completely the AV fixture is embolized. The next case, the renal AVF type 1. You can see the dilated renal artery and dilated drainage vein. This is a selected renal angiography. You can see the very tortuous and dilated fistula. Also in this case, I use balloon for the flow control and I embolize this position using coils, multiple coils. It's a final result. So the type 1 AVM is either very easy to embolize because it's not so difficult to advance a system to the shunting point. Only the risk is a coil migration. So this is our result between the 2007 and 2018. We treated 15 cases of renal type 1 AVMs. And among them, in the 5 cases, very minor renal infarction occurred because the normal artery branched from the very close to the shunting point. However, before the procedure and after the procedure, there's no change of the creatinine level. So next I show the type 2 renal AVM. I think that it's a very rare case. So in the type 2 AVM, the embolization of the initial venous sac is required. However, the approach to the initial venous sac is sometimes very difficult. Of course, it's possible that transvenous approach to the initial venous sac is useful. However, from my opinion, in the most cases, it's very difficult. So the transarterial approach or direct puncture of the initial venous sac is also useful. I show one case. So the flow is so fast, so sometimes it's very difficult to recognize the type of the renal AVM. So you can see the schematic drawing of the renal AVF in the right side. Here is the initial venous component. At first, there is a multiple feeding artery. And this is a shunting point. So first, I selected the multiple feeding arteries and embolized using glue. After that, I selected the largest one. So this is the shunting point you can see in the circle. But at that time, I couldn't advance the micro cursor to the shunting point because this art is so tortuous. So I started to embolize just proximal to the shunting point, but also flow is so fast. But under flow control, I embolized this largest feeding artery using coil and glue. However, of course, you can see that there's a residual flow because this is a type 2 renal AVM. So far, I embolized only the feeding artery, but the target should be the initial venous sac. So I selected another feeding artery. Now that we can reduce the flow, so we can recognize the shunting point very clearly here. So I advance the microcuts more distal position. And this is the shunting point. This is the initial venous sac. So under flow control, I inject glue. Now you can see that the glue fills the initial venous sac. And I remove the microcursor. It's a final result. AVM completely disappeared. So when we treat the type 2 renal AVM, the most important point is the target is the initial venous sac. This is a CT scan after the embolization. There's no AVMs, and the renal infarction is very minimum. So this is a paper from the Korea. Also, you can see the type 2 renal AVMs, and they failed to approach to the initial venous sac transvenously. So they decided to puncture the initial venous sac using the PT chiba needle, like this photo, and they insert the coil into the sac, and also they use alcohol. And finally, the AVM disappeared completely. So it's the same as the peripheral AVMs. So direct puncture with the initial venous component also another option. But is it really safe or not? I don't know. But it's one of the options. So next is type 3 renal AVM, which is corresponding to the sarcoid AVM. So in this type, we must advance the microcatheter as close as possible to the fistula, and embolization should be performed by the liquid embolic materials. So if you use coil, what's happened? Of course, this is not my case, but in this case, another doctor used a coil to embolize the type 3 renal AVM. However, you can see that there is a massive renal infarction, and also there is a residual AVMs. So you should not use coils in type 3 renal AVMs. So I'll show you the case. You can see the multiple fistula between the arteriole and the venule in the upper lobe of the kidney. So we selected one of the fistula using a microcatheter, and then we inject glue. You can see that the glue filled the nidus completely. However, of course, there's another multiple fistula. So I selected another fistula and inject glue. The important point is that this is a wedge injection. I wedge the microcatheter to the shunt, so I can push the glue continuously. Also, this is another branch. I inject glue under wedge injection, so the glue fills the abnormal nidus completely. So wedge injection is the most important technique. This is the final result. What do you think about this? Nidus completely eradicated, disappeared. There's no complication. But of course, it's a very lucky case because I could embolize the whole nidus, abnormal vessels. However, in the most case, we can't embolize whole nidus. But of course, we embolize maybe 80% or 70% of nidus. Maybe we can reduce the risk of the hematuria, I think. So this is a take-home point. Recently, the congenital renal AVM is classified into 3 types based on the peripheral AVM classification from Korea. So the treatment strategy must be considered based on these types and the vascular architectures. Type 1 is the AVF, which is corresponding to the classical aneurysmal type. And the type 3 is the fine shunt between the arterioles and the venules, which is corresponding to the classical sarcoid type. And finally, the type 2 is a very new one. This is the shunting between the multiple arteriole to the initial venous sac. And the target is the initial venous sac I showed you. Thank you for your kind attention.
Thank you, Dr. Inoue. It's a very nice presentation. So now I think there's a question and the discuss about the end of this session. So,